Hello, everyone, and welcome to today's webinar in the Public Health webinar series on blood disorders. This webinar is presented by the Division of Blood Disorders at the United States Centers for Disease Control and Prevention, also known as the CDC. I'm Dr. Bobby Tran, and I'm delighted to serve as today's moderator. I'm an assistant professor in the Department of Hematology and Medical Oncology at Emory University School of Medicine here in Atlanta. And I work as an adult classical hematologist at the Hemophilia of Georgia Center for Bleeding and Clotting Disorders of Emory. I'm delighted to introduce our presenter, Dr. Christine Kempton. Dr. Kempton is a professor in the Department of Hematology and Medical Oncology and the Department of Pediatrics at Emory University School of Medicine. She also directs the Hemophilia of Georgia Center for Bleeding and Clotting Disorders of Emory. In addition, she serves as the Vice Chair of Faculty Development in the Department of Hematology and Medical Oncology at the Emory University School of Medicine. We are both delighted to be with you today and appreciate the invitation from our colleagues at CDC's Division of Blood Disorders. Before we begin, I'd like to go over a few helpful hints for joining this webinar. Upon joining the webinar, you will see two audio options. You can opt to either listen via the speakers on your computer or by using your phone to call in. If you use the phone option, then the webinar toolbar will provide you with the phone number, access number, and audio pin. All audio will be muted, and at the end of the presentation, there will be time for questions. To submit a question, please use the questions area on your toolbar. We will respond to as many questions as we have time for. Today's webinar will last approximately 1 hour, and please note that this webinar will be recorded in the event that you wish to view it later. So first, we will begin today's webinar with two brief audience poll questions in order to get to know you a little bit better. So please respond to the first poll question now. All right, after you've completed the first poll question, there should be a second poll question that also pops up, and this will give us a better idea of which region of the world that you live in. So please also select a response to this question as well. All right, and thank you very much for answering those questions. And so today we are looking forward to providing you a deeper dive into aging in people with hemophilia. As a reminder, we will have a Q&A session at the end of the presentation, so please feel free to submit your questions throughout the presentation and we will address them accordingly. With that being said, it is my pleasure and honor to invite Dr. Kempton to begin her talk on this important topic. Dr. Kempton?
Thank you for the kind introduction and to the CDC for the invitation to talk today. My talk is titled From Zoomer to Boomer, Aging with Hemophilia. These are my conflicts of interest, a few presentations and participations in advisory boards, as well as research funding from Novo Nordisk in the past. So the objectives today are really to be able to describe complications of hemophilia that occur with aging, as well as understand the impact of hemophilia on cardiovascular disease, and be able to describe how aging may impact hemophilia care and the role of the treatment center in supporting the aging transition. So hemophilia has changed dramatically over the last century. So back in the 1940s, the treatment was whole blood, and the life expectancy was around 13 years. In the 60s and 70s, we had home infusion therapy, and unfortunately, the HIV and hepatitis C epidemic in the 70s and 80s. By the 90s, we got recombinant products and plasma-derived virus-free products, and then later extended half-life products, non-factor products, and now gene therapy. So over this time, we've had a near normalization of the half-life for patients, the lifespan of patients with hemophilia. So that is near normal that of the general population. But because of the HIV and hepatitis C challenges that we had in the 70s and 80s, we really don't have a lot of patients, as we would have expected, really in advanced age. So we're starting to see an increasing number of older patients, and I think this is only going to increase with time. This is data here taken from the CDC website that represents data from the community counts. You'll see the different severities for hemophilia. This represents both hemophilia A and B in mild, moderate, or severe. And most notably over here with severe disease and those that are over the age of 65. In this large population of patients, there's only 373 patients with severe hemophilia that are over the age of 65. And if you think about it, those that were born in 1970 would be about 53 now. So those are really the people that experience the brunt of the HIV and hepatitis C epidemic. So we really just don't have that many patients that are in that older age group, let alone truly elderly. And as you can see here in the population that's in the 20 to 44, it is a pretty big year span, but it's a big group of patients. In total, nearly 12,000 patients for people with hemophilia in this age group. And over the next 30 years, when they're going to be anywhere from 50 to 75 years of age, they're in the absence of another unexpected threat to their lives will be in the older age group and likely to be 65 or older. So this is something that we need to be increasingly paying attention to, as well as anticipating workforce needs for caring for patients with hemophilia and other bleeding disorders as they age. So what are some of the challenges with aging that we can think about? And I broke this down, some of it's a little bit arbitrary, but those that are potentially caused by hemophilia or exacerbated by hemophilia. And these include, of course, musculoskeletal decline, osteopenia, osteoporosis, balance falls, pain, immobility, hypertension, which I'll talk about a bit, neurocognitive issues that may occur with intracranial hemorrhage. Depression already is a problem in hemophilia, and it may be exacerbated in advanced age with social isolation, and of course, advanced liver disease. The management, in another group, they may be impacted by hemophilia, or really it changes the hemophilia care. So cardiovascular disease isn't any worse in patients with hemophilia, but it's really challenging. I'm going to touch on this later in the talk. Cognitive decline is a challenge for patients that are aging and may make hemophilia care worse, as well as cancer is definitely an issue, and I won't be talking about that today. So let's dive a little bit into osteopenia and osteoporosis. So taking the general population, not even specifically to hemophilia, but osteoporosis is a common disorder at aging, and it affects 2 million people worldwide. 5.7%, and this is an older estimate, but I think still holds true, 5.7% of men 65 years of age or older have osteoporosis already. And in the US, that's about 1.5 million men with osteoporosis. You can see here in this chart that it affects women more than men, but definitely men are affected, and there may be some racial differences as well. So why is osteoporosis a big deal? Well, it's the fractures that happen because of osteoporosis. And 39% of osteoporotic fractures occur in men. And there's a 20% mortality that's associated with those osteoporotic fractures. It increases costs and it increases morbidity. So this is really a significant problem worldwide in the general population, and it's only going to be a little bit worse in our hemophilia population. So the classification of bone density is made by doing a bone densitometry, or DEXA. The use of the DEXA is a little bit different in those less than 50 versus those over 50 years of age. In those less than 50 years of age, we use the Z-score, which is standard deviations away from the aged matched controls. So low bone density in someone that's below the age of 50 is the terminology that you would use, and is considered if the Z-score is less than 2, or 2 standard deviations, bone density is 2 standard deviations below that of aged matched controls. If a patient less than 50 has low bone density and a fragility fracture, then you can give them a diagnosis of osteoporosis. But really, osteoporosis or osteopenia is a diagnosis for those over 50 years of age. It's based on DEXA alone. In those over 50 years of age, you use a T-score, and that's matched to young normals. And osteopenia is considered a T-score that's between -1 and -2.5, and osteoporosis is when the T-score is below -2.5, or the bone density compared to matched young normals is 2.5 standard deviations below the mean. So over the years, there's been a lot of publications around bone density in patients with hemophilia, and this nice meta-analysis here kind of puts it all together in comparison of the studies that compare to the general population. So we see here in the top portion of this graph, the comparison with in adult studies in comparison to the general population, and an overall estimate that there is a lower bone density in patients with hemophilia compared to their non-hemophilia counterparts, and the same in the pediatric population. So this is really where the weight of the evidence tells us that patients with hemophilia have lower bone density than the general population. The prevalence of low bone density from studies is quite variable, because the studies themselves are quite variable, both from the population, the age of the population, as well as what's reported in terms of bone density, Z-scores or T-scores. So this is a collection of studies here. The yellow is the children, the blue are the adults, with ranges of osteopenia or low bone density, and the sort of checkered blue in the middle being osteoporosis. And what we see here, the point of this is that low bone density can affect patients with mild disease, moderate disease, and severe disease at a proportion that ranges from 8 to 43%. So a substantial prevalence in this population that is notable and worthy of attention. So I'm going to touch a little bit on why this might be happening. And to do that, you need to understand a little bit about bone balance, bone homeostasis. And potentially, like the formation of clotting, where you get a clot and you break it down, you get a clot and you break it down, and that's kind of happening through our bodies much of the time. Bone formation and breakdown is also happening as a normal part of bone maintenance, of homeostasis. So the breakdown happens with osteoclasts in these pits, and then the formation is osteoblasts that are coming back behind the areas that have been broken down. So this is a normal process of bone breakdown and bone formation that is in balance to maintain a normal bone strength. When it's out of balance, either with decreased formation or increased osteoclasts or resorption, then you may have reduced bone density. So there have been a couple of hypotheses as to how hemophilia may be associated with low bone density as an intrinsic bone disease. The first is that von Willebrand factor and factor 8 may lead to increased osteoclastogenesis, and that's because factor 8 von Willebrand factor complex binds to osteoprotegrin, which is an inhibitor of rank ligand interacting with rank, and that interaction is needed for osteoclastogenesis. So when you don't have your inhibitor, so there would be a reduction in absence of von Willebrand factor, factor 8, there would be a reduction in the the inhibitory effect of OPG on the rank-ligand-rank interaction, reducing the inhibition on osteoclasts, leading to osteoclastogenesis. That's a lot of double negatives, so it can be a little confusing, but essentially leading to increased bone resorption. Another potential, and one that I favor a little bit because of some evidence that the evidence of hemophilia B as well is a contributor to, is a risk factor for low bone density, is that the osteoblasts themselves have thrombin receptors. Thus, the generation of thrombin can influence bone formation. And insufficient thrombin may lead to insufficient bone formation. In mouse models, there have been a couple, and one looking at factor VIII deficiency in a mouse model demonstrated similar bone formation that increased osteoclast lines, perimeter of the bone, and their conclusion was that there was increase in bone resorption, so that the osteoclasts were overactive. In studies that we did here at Emory, in both male and female knockout mice, so these weren't carrier mice, they were total knockouts. In the male mice, which is the bottom panel, and these were from 0 to 6 months, we saw that there was a decrease in bone formation in these young mice that had no factor VIII present. Whereas in the female mice, there was actually an increase in bone resorption in the young mice, young female mice. So some differences here we saw between male and female mice. Interestingly, I think, so in addition to the hemophilia itself being potentially a bone, leading to a defect in bone formation or metabolism, other risk factors would include joint disease or joint bleeding, which leads to inflammation and activation of pro-inflammatory markers that lead to bone destruction, and those also then lead to more systemic bone destruction. So some of the challenges of hemophilia is that the etiologies of osteoporosis may change over time from potentially early defects in bone formation to increase in bone destruction when there's advanced joint disease. There's been some consideration around how would emicizumab and bone metabolism impact things. If factor VIII is important for bone metabolism, will we see an increase in bone disease or abnormal bone metabolism in the setting of emicizumab? This is data that was gathered as part of the Haven study. And the top panels show markers of bone formation, and the bottom panel shows markers of bone resorption. And I think you can all see here that over these 80 weeks, there was really no difference in these markers, suggesting that there wasn't an impact on emicizumab on bone formation or the lack of routine factor VIII replacement therapy in this group of patients. So in all that theoretical information is good and interesting. It's good for clinical studies and scientific investigation, but what are we supposed to do for the patients that are in front of us? And these are my practical recommendations. At our center, we do get DEXAs in persons with hemophilia that are over the age of 50 years, or those that have had a low trauma fracture regardless of age. And we're looking to identify patients with osteoporosis that may be at increased risk for fracture in the future. Once we've identified somebody with osteopenia or osteoporosis, we look for secondary causes, including a low testosterone, vitamin D deficiency, hyperparathyroidism, and refer to endocrinology for discussion of treatment. So the take-home points for this section are that low bone density is common in advanced age, and low bone density can lead to fractures, which are associated with significant morbidity and mortality. People with hemophilia are at greater risk for low bone density, thus exacerbating this already significant age-related problem. The mechanism for low bone density in persons with hemophilia isn't clear, and it's likely multifactorial, with the mechanisms changing at different life stages. Recommend considering a DEXA screening for patients over the age of 50 years and in anyone who experiences a low trauma fracture. Other disorders that can contribute to reduced bone density should be investigated and treated, and treatment of osteoporosis should follow standard treatment protocols for men and women with osteoporosis and occur in conjunction with an endocrinologist. So shifting next as a logical next step from osteopenia and osteoporosis, since we're most concerned about fractures, is to balance and falls as a common aging problem. But in patients with hemophilia, this is going to be more significant, as evidenced by this study that looked at 20 patients with hemophilia. 70% of them had severe disease, and they had 20 age-matched controls. This wasn't an elderly population. The median age was around 40 years for both groups. And in this population, 50% of the persons with hemophilia, compared with 10% of controls, had one or more falls in the past year. And in those with hemophilia, the median was around 0.5 falls versus 0 falls in the control. They did observe differences in dynamic balance and joint proprioception between those with hemophilia and the controls that appeared to explain some of the increase in fall risk. So this is a screenshot from a nice site from the CDC that is all about falls. And they provide an algorithm here for fall screening, assessment, and intervention of adults over 65 years and older. Though I would suggest that these really should be applied to patients in hemophilia that are younger. What's the right age, I think, is still a matter of debate. To me, potentially 50 feels like a good age, so there may be those that are 40 that have advanced joint disease that may also benefit from screening for falls. So this site here recommends one of 2 screening tests. There's a Stay Independent, which is a 12-question tool, which feels a little bit cumbersome to me. I like this 3-question option here, which is just if a positive screen, if any questions are answered yes, and those questions are: do you feel unsteady when standing or walking? Are you worried about falling? And have you fallen in the past year? So any positive question to that is a positive screen for falls. Would suggest then that the patients then are assessed for potentially modifiable risk factors, and this would be evaluating their gait and balance, identifying other things like medications that may increase their fall risk, home hazards, orthostatic blood pressure, and visual acuity. These are all things that could be screened as contributors to falls. And in our patients with hemophilia that are not traditionally elderly, it would be probably the gait, strength, and balance, as well as home hazards that we would need to be paying most attention to. And then if abnormalities are identified, then intervening on those is recommended. So to touch a little bit on the screening, the functional tests that can be done to assess fall risk, there's 3 of them that are recommended on the CDC site. The Timed Up and Go test, or TUG. In this test, the individual stands up from the chair. They walk to a line, which is about 3 meters, which should be 3 meters from where they stood, turn around and walk back to the chair at a normal pace and sit down. If it takes more than 12 seconds to complete, it's considered a positive test and increased risk for falling. The 30-second chair stand test is just counting the number of times one can stand up and down from a chair without using their hands in 30 seconds. And in the CDC site as well that outlines this test, there's a series of averages at different age ranges, and you just compare to that average based on age, and if it is higher than average, then that's a positive test. The last one is a 4-stage balance. So 4 different ways of balancing, 10 seconds in each position. The first is feet side by side. Second is in step, so it's touching the big toe. Feet are kind of aligned like this. The other one in full tandem, one heels against the toe. and then on one foot. And so if you're unable to hold a tandem stand for 10 seconds, that's associated with an increased falling risk. So all of these are pretty simple tests that could be done either by the physical therapist as part of a treatment center or by really any member of the team once a fall is identified. And if these are positive tests for balance, then working with physical therapy, whether in your center or referring out in order to improve balance and mobility is the next step. So next, I'm going to touch on hypertension as a major issue that we need to be thinking about in our patients that are aging with hemophilia. So hypertension is a challenge because it contributes to cardiovascular disease as well as renal disease. And really the biggest thing that I worry about is the increased risk with intracranial hemorrhage. There's conflicting evidence whether persons with hemophilia are at greater risk for hypertension, but I would say that the weight of the evidence favors an association. I think something for us to pay attention to because of the consequences of hypertension, but also likely to be more prevalent in our population as well. The hypotheses as to why hypertension may occur more commonly in patients with hemophilia, there's twofold. One is that there's vascular remodeling in the bleeding joints that send out mediators that affect the joint or the vascular wall and can lead to hypertension, as well as renal disease that may result from hematuria or kidney stones, which can occur because of hypercalcemia. So those are two potential reasons why persons with hemophilia are at greater risk for hypertension. So as I mentioned, intracranial hemorrhage is the real concern and the real reason why we need to really pay attention to high blood pressure in our population, regardless of whether it's more common or not. As we see here, although more commonly occurring in the younger age, the youngest of our patients, really right around birth, it does tend to rise again, shown here in this study done by Zanin et al., kind of in the mid-30s, starting to rise again as we age. So this is definitely something that can be catastrophic, very morbid, with a high mortality rate. So hypertension is one mechanism to reduce the risk of intracranial hemorrhage in our older patients. The U.S. Preventive Services Task Force recommends screening for patients 18 to 39 without risk factors every 3 to 5 years, and would suggest that maybe we should be considering all our patients with hemophilia as having risk factors, thus warranting annual screening, as would be the case for those 40 years or older without any risk factors. It's important to notice that high blood pressure, stage 1, is considered anything with a systolic above 130 and a diastolic above 80. So if you've been practicing medicine for a while and haven't paid attention to hypertension management, you may be letting a number of your patients with blood pressures in the 130s over 80s by without any discussions about blood pressure. We really need to be adjusting our talking points around this. And that's really what the treatment center can do, is to counsel patients and to educate them, because they may be coming to see us as really their main medical providers, particularly at younger ages when they have no other health problems. We're the only ones that they're seeing on a regular basis. So we have a responsibility to counsel them about their high blood pressure and what are the next steps they need to take. I don't know that anybody wants to be treating their blood pressure when we're not doing it regularly, but it's an important role in counseling and getting them to the next steps. So I think these take-home points for hypertension is that it's common in patients with hemophilia, and it's likely more common than in the general population. The consequences of hypertension can be devastating, being intracranial hemorrhage. And the Hemophilia Treatment Center's role is in screening, counseling, and facilitating next steps, which include home monitoring and connecting with a primary care provider. So patients often may tell us, like, oh, my blood pressure is only high when it comes here, traffic was terrible. Well, they should still be then monitoring at home and confirming that they're not having routine high blood pressures before we just say, oh yeah, no problem. So moving on to cardiovascular disease. This is definitely a challenge in our patients with hemophilia. So overall, it's been studied a fair bit, and in general, the kind of consensus is that the prevalence is similar as seen in the general population, but the mortality of cardiovascular disease is lower than that of the general population. So breaking it down into coronary artery disease, the sort of practical approach, because the challenges here are management. And the goals here with coronary artery disease is to support therapy as close as possible to the standard of care. Fortunately, current drug-eluting stents require much less dual antiplatelet therapy than in the past. So currently it requires only 1 month of dual antiplatelet therapy, which makes it much easier to support a drug-eluting stent in patients with hemophilia. Previously, we've been recommending bare metal stents, which I don't think is needed anymore. When on dual antiplatelet therapy or when undergoing the PCI, in order to place the stent, we want factor levels that are greater than 50% to support the arterial catheterization that's needed. It can be done through the arms these days, as opposed to needing to go into the groins. During the dual antiplatelet therapy, general recommendations for factor levels range from 15 to 30%. A nice large French cohort study recommended above 20%. So that's kind of the general range for your patients. Once they drop to single antiplatelet therapy, keeping a level above 5% is what's recommended. So it's not impossible to consider patients with coronary artery disease to have drug-eluting stents and having standard of care management of their coronary artery disease. Atrial fibrillation is a little bit more challenging. The risk of stroke may be different. So our utilization application of scores like the CHA2DS2-VASc score, which is sort of a standard way to predict risk of stroke in patients with atrial fibrillation, may not accurately predict the risk of stroke in patients with hemophilia. We don't have a lot of data at all to understand what is the risk of stroke and how do we most accurately predict it. But given that the reason strokes happen is because of stasis and thrombus formation within the fibrillating atria, it's possible that the coagulation defects of hemophilia may reduce that to some degree. So how to take that into account is challenging, and we really don't have any data right now to help us determine what is a patient's risk of stroke. How do we apply or not apply the CHA2DS2-VASc score? So kind of taking what's the general approach in the general population, and then what can we do in our patients with hemophilia? I think the general consensus is to pursue approaches like cardioversion, ablation, left atrial appendage occlusion when possible, things that will reduce the risk of stroke without long-term need of anticoagulation should be considered. It's important to note that aspirin alone is not effective stroke prevention in patients with atrial fibrillation. It's no longer considered an option, so it's really nothing versus anticoagulation. With anticoagulation, we want to have levels that are greater than 20 to 30%. So this is going to be difficult in patients really that just aren't there already. So in your patients with mild hemophilia that are maybe in the 10 to 15% range, it's going to be really hard to give them prophylaxis in order to support anticoagulation. In your patients with severe hemophilia, it's going to be pretty difficult to get them consistently in a range of 20 to 30%. That's going to support full dose standard anticoagulation. Things to consider, though not with any true literature behind them, would be the use of emicizumab. That would support some level of anticoagulation. I'm not sure I would feel comfortable with full dose anticoagulation on emicizumab, but literature may be coming out in the future with that. Or potentially using lower dose DOAC, such as occurs in those that are elderly over the age of 85, renal dysfunction, low weight, some combination of those. The dose of DOAC is, the apixaban would be 2.5 twice a day rather than 5. Whether that's useful or not, again, there is really no data. It's just speculation as to whether that would be something that would be reasonable to consider. So in thinking about patients using emicizumab for older patients and those with thrombotic risk factors, there is some data that comes out from the Israeli group. They looked at 17 patients that were over 50 years of age, and in their group looked at their cardiovascular risk factors. 9 of the 17 had at least two cardiovascular risk factors, and 4 of those 9 had prior PTCA or CABG and were on antiplatelet therapy. And as you can see in this top panel A, there was good control of their AVR with the use of emicizumab. The bottom panel shows us the improved thrombin generation, both the endogenous thrombin potential and the peak generation, which were improved, but not any greater than that of controls. And overall, there were no thrombotic events or microangiopathic adverse events in this population. So it was well tolerated and potentially an option, particularly with antiplatelet therapy or low dose DOAC. I think it's reasonable to consider. So overall, we talked some about cardiovascular disease, trying to get to close to standard of care for coronary artery disease, as well as some of the challenges with atrial fibrillation and trying to get to anticoagulation to reduce stroke risk if needed. Outside of the things I talked about, I think there was a lot of other things to consider in our older population. And although elderly is defined as over 60 years of age, there's probably a lot of reasons to be thinking about these things in patients that are younger than that and that have hemophilia, particularly a lot of comorbidities. Frailty is a concept that is often discussed in geriatric and older populations, and this is really age-related vulnerability and decline. There's a wide variety of tools that can be used to measure frailty, and none that are really percolated to the top as the single one to be used. You might talk to your geriatrician at your center, or that you have access to, and see if there's one that they prefer you use in order to screen, and refer then to a geriatrician to really employ some of the more standard thinking for a geriatric population, even potentially if they're not officially geriatric. Important to think about changes in fine motor skills that may impact infusions or injections. And this particularly would be of concern with frequent prior elbow bleeds. There's cognitive decline and a couple of different mini mental assessment tools that could be used. Depression screening, I think, is really important in any population that has a chronic disease, but definitely think about it more in your patients that are elderly. Polypharmacy, and particularly those that are going to be leading to changes in mentation and increased fall risk, are things to think about. This is where you might want to engage with your HTC pharmacist, so start thinking about these things. And lastly, life planning and talking about advanced directives is important. Our patients, particularly when they're in more advanced age, have been part of our treatment and under our care for probably decades. And we probably are the best people to talk with them about some of these really difficult decisions that they're going to be needing to make, and having their advanced directives well documented and written out for their later years. So again, I thank you for the opportunity to present today. I look forward to hearing your questions. Thank you.
All right, so thanks, Christine. And so with that, what we're going to do is we're going to shift to the question and answer section of this webinar. So please submit your question using the questions area on your toolbar. And again, we will try to address as many questions as we can. So Christine, the first question that I have from the audience is, what are the differences in impact of aging on men with hemophilia versus women with hemophilia? And are there differing risks or concerns?
Sure. So that's a great question. I think, as I mentioned, there's potentially some differences in bone density And I screen our women that have low factor VIII activity as well, in the same way that I screen men. Women tend to have less severe deficiencies of their factor, so their joint disease may be less significant, so they may have less of the motor deficits, balance deficits, potentially less fine motor decline. But I don't think we really know that. I think it's really kind of a personalized assessment of patients once they're getting into more advanced age.
Right. And then one question that I had was, you had mentioned that the prevalence of osteopenia, osteoporosis is more prevalent in those with severe hemophilia versus those with mild hemophilia. Do you know of any studies that have looked at the prevalence of bone health in individuals who have been on prophylactic factor replacement since a very young age, and so therefore kind of eliminating kind of the differences between severities?
Sure. Yeah. And there was one study, I think it was out of Sweden, that did evaluate patients that were on prophylaxis and saw some reductions in the proportion of patients that had low bone density. It was fairly small, and they were a fairly young population. So in our study that we did in the patients that were over the age of 50, we did see a good proportion of patients with mild disease that had osteoporosis and osteopenia. It was at the younger ages where there was a more dose-response relationship with low bone density under the age of 50. So I think it's not, to me, not totally known. If you have perfect joints and factor VIII replacement for your whole life, would you not have low bone density? My read of all the literature is not entirely that. I don't think it would completely eliminate the risk, but it would eliminate part of it. And I think it's, again, multifactorial. There's multiple things that come into play with it.
Sure. Okay. So one question from the audience is that are there current protocols that are being developed for prostate health issues among men with hemophilia, such as enlarged prostate or prostate cancer? And there seems to be a lack of research in this particular area, even though it's, the second most common cancers among men, especially with older men getting BPH.
Sure. So I would say my general approach to patients for cancer screening or cancer is to get them the standard of care. And typically that can be achieved with the factor replacement, that there isn't any, I think, chemotherapy where the duration of cytopenias are, so significant. I mean, really would be in the transplant setting, and then you would use a pretty aggressive replacement therapy for a short duration of time. So with most other therapies, you're having, you're treating through biopsies, diagnostic testing, other procedures, which can be for short periods, and then potentially with some mild thrombocytopenias that also can be managed. So I would really, my strategy would be to get them the standard care. I think our role as treatment centers, often in these settings, is to encourage them to get the screening that they need with the care providers that do that screening best, which is their general doctors. And we can support them. And I think it's good to sort of check through, have you gotten your usual annual screening? And if not, encourage them to get it and let them know that their hemophilia shouldn't be a barrier to them getting the appropriate screening that they need.
I think one of the things that I find challenging with some of the younger patients is whenever I talk to them and have them connect with primary care, trying to to ensure that there is adequate screening for such conditions like hypertension and whatnot, is that they typically don't follow up with the primary care, at least from annual visit to annual visit. What are some of the strategies that you've kind of utilized to try to increase the success of getting them to connect with a primary care provider? Because I think a lot of the things that you've mentioned, really are important reasons for them to be connected.
Yeah, I can't say I have any go-to successful strategy. I myself actually am terrible at going to a primary care doctor, so it's hard. I mean, I think it's just understanding what their own barriers are. What is it that is keeping them and preventing them from doing it? It's often time or potentially understanding of what they're supposed to be doing. So reviewing and discussing, what are the standards for their age group, and keeping them healthy, and understanding that neglecting things kind of like dental work, if the longer you let it go, it's just going to become more and more of a pain and a problem. So if we let our health kind of decline, and by the time we're 40, 50, 60, things are much more difficult and requires much more intervention and challenges to get on versus staying on top of it. So I think those are some of the strategies, but I can't say that anything has been proven effective just yet.
Okay. So one question that came up was that with patients having cardiovascular disease, one question that a couple of the other providers kind of struggle with is if they are faced with the option of either doing a stent versus a CABG, and what has been your strategy as far as recommendations for these patients if the patient's disease is severe enough that they would need consideration for CABG?
Well, I think in the end, you are kind of on aspirin therapy either way as your long-term strategy. So it's really the difference is the short-term risks with the CABG versus the PTCA. And typically, and like with a lot of things, want to understand what would the cardiologist be recommending, or the cardiac thoracic surgeon be recommending in the absence of hemophilia. And then what can I do to get them that standard of care, and how far off from the standard of care is the choice, is the PTCA. If the PTCA is really like, we would not be recommending this except for the fact that they have hemophilia, we would, if they didn't have hemophilia, we wouldn't put this on the table at all. We would just do a CABG. I would do what I could to get that patient a CABG and support them through with the factor replacement therapy. If they're like, well, they're kind of similar, they're the same, then sure, let's go with the PTCA first. But in general, my sort of theme is to try to deliver as best as I can the standard of care, and try to take the hemophilia as I can, as much out of the picture. And if I can do that for a short period of time for a surgery or a procedure, that's easy. It's really for more the long-term issues that are more challenging with anticoagulation, I find.
All right. And then as far as, let's see, since many women who have hemophilia have not been diagnosed and treated throughout their lives, would there be notable differences in aging in women versus men, and the consideration for possible microbleeds is something that came up in the questions as well?
Yeah, I think if there's subclinical bleeding that's been happening and they have joint disease, then that is a potential that they're going to have some mobility and balance issues for sure. As I mentioned before, I think the factor VIII deficiency in women warrants DEXA as well, and warrants consideration of course, of their fall screenings and those sorts of things as well. In my experience, although present, the severity may not be as quite of the same range. So it doesn't, it's more, they're mild hemophilia, which in the advanced age has significant implications, and they would be the same for women and men.
Okay, all right. And then I think one question that came up also was that in patients with sustained remission with hepatitis C, what is the current liver monitoring that you are suggesting for these patients?
So ideally, everybody with hepatitis C is treated to remove the viremia. My current understanding would be that stage 3 fibrosis or more advanced fibrosis cirrhosis should receive hepatocellular carcinoma screening every 6 months. And then you also periodically, and I don't remember if there's necessarily an exact frequency, but periodically also want to understand, definitely with cirrhosis, whether varices are present or not. And then with the stage 3 fibrosis, probably do an EGD at some point as well. But I really engage my liver colleagues for this as well.
Okay, all right. And you kind of touched upon this, and with cognitive issues, I think that definitely presents adherence issues, as well as maintaining good adherence to their factor replacement or non-factor replacement products. What are some of the strategies that you've tried to engage their families or their friends and whatnot to try to help with this recognition that there is, some cognitive issues and whatnot?
So to support adherence to factor replacement therapy, is it?
Yes, to try to, and then also, help them keep their appointments straight, and most of them are on other medications, so kind of touching on the other topic that you mentioned with polypharmacy as well.
Yeah, so again, I think it's really just understanding what are the barriers to adherence or medications. Is it the remembering? Is it the doing? Is it, well, I remember, but I don't like it, so I don't want to do it? Or, I think a lot of times there's also self-talk around, do I need it? I don't want to do it today. I don't feel like I need it today, so maybe I'm going to do it tomorrow, kind of thing. So I think understanding that perspective of where the patient is coming from and what are the stories they tell themselves that talk themselves out of doing it, or prevent them from staying on schedule, and then helping identify what are some strategies around that. Sometimes, I think patients with emicizumab, this doesn't apply necessarily to the exact elderly, but maybe they started their infusions on a Tuesday because that was the day they came to clinic, and Tuesday really isn't the day for them, the best day for them to do their infusion or injection, but they stick to it because that's the day that they started. So problem solving around what's working for them, and what's not, and then what are different ways that they can get around to make it better. I don't think there's exactly a one-size-fits-all sort of trick to do for patients, but it's really individualizing it and then pulling in whatever resources they have around them.
All right. Well, thank you very much, Christine. In the interest of time, we would like to thank everyone for joining us today. So thank you again, Christine, for your excellent presentation. And Christine, if you could advance to the next slide for me, please. We'd also like to thank our colleagues at the Hemophilia Federation of America for hosting today's webinar. Very shortly, you will receive an email asking for your feedback, so please respond to this email with your comments. And if you have additional questions about today's presentation, please feel free to contact Cynthia Sayers at the email listed there. And today's webinar will be archived, and the content will soon be available at the CDC's Division of Blood Disorders website, as shown on the slide. And thank you again for joining us today, and have a great afternoon, okay? Thanks.